possiamo cominciare se anche da fuori arrivano gli ultimi che si accomodano. Comunque direi che possiamo dare inizio al secondo giorno, al venerdì, alla prossima sessione, alla prima sessione. Benissimo, sono già i moderatori pronti e quindi direi che potete far venire il primo speaker. Prego.
Grazie.
Adesso ci sarà la dottoressa Luca Vigo che ci parlerà di ai prosegue di EYEAlla, quarta.
Allora, buonasera a tutti. Intanto permettetemi di ringraziare Giovanni Tedesco e Luca Vigo per avermi voluto ancora una volta nella quarta edizione di questo congresso, che diventa sempre più bello, sempre più interessante, in terra calabra, che con questo mare non è poco. Io vorrei andare avanti, ma...
Arriva.
Ok. Innanzitutto vorrei appunto le forme ovviamente iposegretive ci hanno insegnato, abbiamo imparato che sono l'alterazione del disequilibrio della superficie oculare e prevalentemente legata ovviamente alla riduzione, al fallimento, all'infiammazione delle strutture che producono il film lacrimale e della superficie e anche o a riduzione dello stimolo neurogeno appunto che produce il film lacrimale e l'ammiccamento. Però le forme iposegretive pure ci dobbiamo ricordare che il DRY non è una malattia multifattoriale, è una malattia che ha grande influenza con i fattori ambientali e quindi in realtà di trovare una forma solo francamente iposegretiva è molto raro, ma più frazioni delle altre componenti. Quindi le forme iposegretive pure sono veramente molto rare, sono legate soprattutto, come dicevamo, all'infiammazione, a patologie soprattutto di natura infiammatoria come la Sjögren o forme non Sjögren, patologie autoimmuni, patologie che hanno una componente sistemica infiammatoria molto importante come l'entidoide, come graft versus host disease, e anche forme in cui invece c'è proprio un'alterazione del riflesso neurogeno che stimola la secrezione lacrimale, come per esempio le traumi, le patologie del sistema nervoso centrale, nelle forme post-chirurgiche. E qui ho finito. La diagnosi ovviamente è una diagnosi che facciamo sempre, sì, grazie, è una diagnosi che facciamo sempre ovviamente utilizzando degli algoritmi che a noi sono più familiari. Quello che di solito la letteratura ultimamente sancisce di più è quello utilizzato dal tifos, quindi facendo riferimento alla presenza della sintomatologia, facendo riferimento all'alterazione dell'equilibrio e della stabilità della superficie oculare misurando il break-up time, la presenza di aumento dell'osmolarità se la possiamo calcolare, ma soprattutto la presenza di colorabilità della superficie oculare utilizzando i coloranti vitali, in particolare il verde di cristalina, soprattutto per evidenziare l'infiammazione e l'alterazione appunto delle cellule epiteliali della superficie. Non dimentichiamoci mai di dare un'occhiata sempre all'ammiccamento e di guardare anche la distribuzione delle rotture del film lacrimale, perché anche quelle possono essere un'indicazione anche del tipo di più o meno dei viveri presenti sulla superficie oculare. Quindi nelle forme deficitarie, quindi di uno o più componenti della superficie oculare, saremo attenti soprattutto per esempio per individuare il deficit lipidico, quindi una ridotta dei viveri della componente lipidica del film lacrimale, soprattutto per esempio l'interferometria o la spremitura e alla qualità del medio sulla superficie che fuoriesce appunto dagli orifizi ghiandolari, la meniscometria, quindi guardare con lo spessore meniscolacrinale, il cutoff è stato stabilito al di sotto di 0,20 mm, anche utilizzando magari dei strip meniscometri, quindi il famoso Schirmer, il fenolo oppure l'OCT, e per le forme tipicamente in cui invece c'è una ridotta produzione della componente nociva del filacrinale, con un'attività sicuramente ci danno un'impressione maggiore, migliore, e se poi riusciamo ad avere una citologia in pressione la diagnosi sicuramente ancora più certa. Questi sono i quadri che ci possiamo trovare davanti, quindi grande infiammazione, vedete il danno epiteliale. Più frequentemente avremo delle alterazioni severe della distribuzione filacrinale come una keratopatia filamentosa. E cosa fare? Davanti ci troviamo i pazienti, i loro sintomi, i loro segni, i loro disagi, quindi qualcosa dobbiamo fare. Di base la terapia della superficie oculare e delle alterazioni è ristabilire l'equilibrio, quindi cercare il trigger, risolvere il più possibile l'alterazione, quindi l'incrementazione della componente del filacrinale, interrompere il circolo vizioso. Ovviamente questo intervento sarà sempre più complesso quanto più cronica è la condizione, quindi quanto più avremo alterato la componente immunologica presente sulla superficie oculare, introducendo soprattutto alterazioni della cosiddetta immunità adattiva. Di base, quindi la terapia vuol dire correggere i danni epiteliali, correggere l'infiammazione, l'instabilità del filacrinale, il danno neurogeno. E la terapia è una terapia sempre piramidale, si parte da interventi che vanno direttamente sul lifestyle, come ci hanno il dottor Toios ci ha illustrato bene: la dieta, idratazione, la cura del sonno, attenzione agli ambienti circostanti, l'umidità, l'esposizione al sole, i medicamenti, i cosmetici, quindi partiamo anche da questo. E poi ovviamente i capisaldi nelle forme cosecretive sono soprattutto due, e sono la terapie che vanno ad intervenire sulla quota infiammatoria e quindi anche immunoregolatrice, ho detto che soprattutto sono frequentemente patologie infiammatorie, e quindi i corticosteroidi, la modalità con cui sono somministrarli, ma soprattutto, e quella è la mia esperienza, inibitori della calcineurina, quindi ciclosporina, tacrolimus, ma anche qualcos'altro come ad esempio potremmo usare fattori che vanno come i secretabili, oppure sostituti lacrimali, o interventi che vanno a mantenere maggiormente, cercando di mantenere maggiormente e conservare maggiormente la componente del filacrinale sulla superficie oculare, come ad esempio l'applicazione dei contemplati. E quindi lacrime artificiali, a seconda della carenza maggiore, potremmo utilizzare, adesso abbiamo veramente un panorama amplissimo, le terapie antinfiammatorie, i secretabili, adesso vi vedremo anche meglio anche nelle relazioni, la neurostimolazione della produzione dei vari componenti del filacrinale, utilizzando i farmaci, utilizzando i stimoli elettrici, utilizzando anche device come la therapy oppure gli esercizi di blinking. La dieta, che abbiamo visto l'omega 3, utilizzare il contemplare, a volte le lenti sclerali, se abbiamo un danno molto marcato, soprattutto la sintomatologia dei pazienti è importante, così come usare gli occhiali che i muscle glasses, quindi che mantengono le camere umide sulla superficie oculare, e anche, se possiamo, degli interventi biologici per rigenerare la superficie oculare, rigenerare sia la trasmissione nervosa, ma anche la riparazione epiteliale. Tra i secretabili, quindi con gli interventi, ora avremo anche relazioni sicuramente più complesse, possiamo utilizzare secretabili topici come il diquafosfol, purtroppo però non si ritrova in Italia, oppure orali, tipica la cloralpina, la cineminina, o sempre il diquafosfol preso per bocca, o l'epamipide. E poi la neurostimolazione che può essere elettrica, endonasale, oppure colaria, oppure farmacologica, e ci sono i nuovi farmaci base che vanno a stimolare gli agonisti dei canali ionici, oppure la penicillina e altri stimolatori appunto dell'attività cholinergica, del sistema nervoso cholinergico. I 3 lati artificiali, adesso il panorama è amplissimo, quindi l'importante è utilizzarli, l'importante è conoscerli e capire anche quale può essere il trattamento più adatto sulla componente che è più carente, ma ci sono anche farmaci con attività multipla, che hanno anche altre sostanze antinfiammatorie, osmoprotettrici, vitamine che ulteriormente possono aiutare una superficie così sofferente. Così come il tipo di sostitutura primale che è in grado di aumentare per esempio l'idratazione, la variabilità, ridurre l'attrito sulla superficie oculare, quello che conosciamo meglio sicuramente l'acido ialuronico, ma dobbiamo imparare a conoscere le caratteristiche riguardo il peso molecolare, riguardo la lunghezza della catena, riguardo la struttura, perché per esempio utilizzare un basso peso molecolare, un alto peso molecolare o un prosfincato dipende dalla situazione che abbiamo. Così come se abbiamo condizioni infiammatorie sistemiche come un pentiloide o un graft-versus-host-disease, la terapia sistemica è fondamentale. Ultimamente stanno uscendo anche nuovi approcci farmacologici, come per esempio utilizzando l'urochinasi, che possono essere molto utili. Mi preme poi ricordarmi, e ho finito, l'uso per esempio di terapie rigenerative biologiche in questi casi, soprattutto quando esistono delle alterazioni neurosensoriali, utilizzando la membrana amniotica, utilizzando anche le modalità dalla dosiero, dal concentrato piastrinico anche il cordone ombelicale. C'è un bellissimo poster, se volete vedere, il gruppo della professoressa Galliano, e io con questo ho finito, spero di aver dato spunto per seguire.
Che ci parlerà delle forme iperevaporative del dry eye.
Good afternoon, everybody. Giovanni Tedesco and Luca Vigo for the invitation in this beautiful space. And by the way, Rolando, happy 4th today. Okay. The ocular, I would like to make an introduction for giving an overview of what will be discussed afterwards in much more detailed modality. We all know that the ocular surface is an extremely complex morphofunctional structure, physically and chemically. And the 3 layers model is extremely well known. We will not discuss about that. But what is mostly the patient's belief? Most of the time the patients come to our office thinking they are Romina Fasciani's job. Because they always think most of the dry eye, it is not having enough water in the tears, but it is not the case. It is quite hard to explain them that they actually produce most of the time enough tears, but the fact is that because of our model lifestyle and diet and several comorbidities, everything is going to be changed. And mostly the causes are addressed to the meibomian gland dysfunction. That is the common cause. And you have actually physically and chemically changes. Physically, because you have an obstruction of, due to the keratinization of the outcomes of the gland, and the change of the meibomian itself. That depends extremely by the medicaments that the patients take and the diet. There are so many systemic disorders that have an influence. I will not discuss about diabetes or thyroid disease, which has probably a major influence on the aqueous deficiency, or autoimmune disorders, or gut dysbiosis. I will focus your attention about depression and anxiety, because those patients take regularly antidepressant and hormone deficiency. hormone deficiency is extremely important because testosterone plays the role of fluidification of the mandible, and you have the highest peak in female patients in their 20s. And testosterone in females is not a masculinization hormone, but it's the hormone of the libido, and it's the hormone of the fluidification. In the 40s, you have a dramatic decrease. It reduces up to 50%, and then you have the passing of the time, the decrease by 50% in the 50s, and by menopause you have a strong reduction. Whereas by men patients you have a slower progressive decline by 1% each year after the 40s. So it turns out that in our office it happens that this form of dry eye is actually gender specific. It is very female case. The medicaments, most of the patients which have this problem take antidepressant medicaments, and many of them suffer from glaucoma, and the topic glaucoma treatment, as you know, is very disruptive for the ocular surface. And the blinking rate, it will be in more detail discussed afterwards. The blinking rate of the people's in front of the electronic screen decreases from an average of 22-23 times a minute down to 8 times, 7 times a minute. There are championships of video games of people who are staring because they have to concentrate with their reflexes, and it is even lower, 4 times or 3 times. And they are staring on in front of the windscreen, and they look like staring cows, and that really affects a lot the ocular surface because everything evaporates. We have to consider the ocular surface structure as a complex scaffolding. We have, anytime we have a healthy lipid layer, we have a scaffolding which keeps mechanically balanced all the components of the tear film. We have changes during the inflammatory process because of many reasons. You have a hyperosmolarity, you have a high concentration of pro-inflammatory enzymes, which are so many, cytokines, metalloproteinases, that causes irritation and causes inflammation. How do we control it? First of all, the hygiene of the eyelid daily. In the United States, I've been told that even 60% of the people are affected by Demodex, those mites affecting the eyelids, the eyelashes, and probably depends on the diet, because ultra-processed food makes the change chemically of the mandible, and that is an ideal environment for the growth of the mites. And then you have to reduce the inflammation through topical, low-dose, long-duration hydrocortisone, hydrocorticosteroid, and tetracycline. And once you're not satisfied with the reduction of the inflammatory matrix, then you have to point the functional recovery through the devices, the medical devices, which are well discussed in this forum, now available. These are the symptoms: bleaching, blurred vision, burning, the Sahara Desert feeling, and pain. But why pain? Because statistically, 120 million patients worldwide suffer pain directly caused by dry eye disease, and objectively, we can admit that only clear-cut and clear rare diseases such as Sjogren or pemphigoid directly cause pain. But all the other patients, I've been using for the past 4 years the tear check. It has been shown yesterday. The examination, the following the proper test in the dry eye patient is extremely time consuming. It is time spending. So once you have a system which in few minutes gives you breakup time, blinking rate, OSDI index, and osmolarity, and above all, micrography, you save a lot of time. Thank you, Benitez, for your wonderful presentation yesterday. It is very important. The changes that you see through the confocal images, the changes that you have in the cornea, leads to hypo or hyperesthesia. Most of the patients who complain about suffering, about pain, are hyperesthetic, generically. And that means that it is a neuropathic pathway and not neurotrophic. Exactly what Benitez yesterday said. It is very important to make a distinction about the two different pain-transmitting pathways. All the patients that we see, actually, exactly because they complain a lot, are hyper-aesthetic. So, in the summary, Form und Funktion. We have, if we have an intact scaffolding, we have an intact function. And the most important factor is the quantity and the quality. The quality is disrupted by the hyperosmolarity, irritation, inflammation, as you see. And the king of the test for concerning the hyperevaporative dry eye is the mammography. But now I stress you a critical point. I am a fan of the clinic. The tests are very reliable, but sometimes there is no correlation whatsoever between the clinic and the test. Why are patients with healthy functional ocular dispersion and no symptoms, with only 4 meibomian glands, we are functionally in order out of 25, and the other way around, you have patients who complain about pain with 20 meibomian glands which are functioning out of 25. It all depends on this neuropathic pain which doesn't correlate, doesn't correspond to our mammography. So it is very important, the mammography, but guys, remember, try to consider there is sometimes no correlation. The clinical alteration of the meibum. I already named the steps that you have to follow to recover. And the end, the one that I have been using for over the past 5 years, intestinal light plus low-level light therapy. This and other treatment, which will be discussed afterwards, beyond the well-objectable functional recovery, has an enormous psychological impact for the patient. Thank you for your attention.
Grazie al collega Dani. We introduce now Victor Perez with TRPV1 receptors and dry eye.
You're new here, Victor, but this is the way I
Giovanni, grazie per aver la presentazione al Congresso del secco. Un piacere stare qui. And thank you everyone for being here. Un piacere to the organization as well. You know, as chair of the TIFOS report 323, it's very nice and rewarding to see that we're already talking about the new modifications of what we try to do with the 2-3 report. So thank you for that. And what I'll try to do today in my talk, and I'll include the TRPV1, don't worry. What I'm going to try to do is to push the envelope. Because when I accepted to be the chair for the TIFOS 2-3 report, this is the direction I really want to go. Precision medicine. And that may be step 1, but we need to move forward. So what I'm going to do today is give you an example of how I think we should move forward and how we bring it to you in clinical practice. And these are my disclosures. And then, of course, the problem is, and the way I think this is that why we don't do better precision medicine in dry eye. I mean, they do it in cancer, They have amazing precision medicine cancer for certain tumors. They know what their phenotype is, they know what the genotype is, and they give the perfect chemotherapy for these patients. They don't give all chemotherapy for the patients because you're going to have non-responders and responders. So what I want to push for you, the message, and I can tell you because Europe has been amazing in developing new therapies for ocular surface disease. So I'm going to push you a little bit more because I think what we need to do is to develop better companion biomarkers that will tell us who are going to be the responders for EYEAlla, for anti-inflammatory therapies, for anti-lubricants, etc. So I really think that we have the unique opportunity to do precision medicine in ocular surface. And I'm going to give you 3 examples of that. First, dry eye is a perfect field. This is a permutation of my wife's work. She'll be talking tomorrow. But we call dry eye and we put everything on this big umbrella where we call it dry eye. And now we know, this conference has been great that we actually break it out in the different topics. We have toxicity, we have anatomy problems, we have neuropathic pain, and I'm an immunologist. So for me, all this umbrella is covered with a little of inflammation or a lot of inflammation. And that's why anti-inflammatory therapies are complementary therapies to what we do. They might not be the main form of treating ocular surface disease, but they are complementary. And I know we have different talks after mine talking about the inflammatory therapies. But let me give you a couple examples of how I think about it. So at the ocular surface, compared to cancer or other fields, we have access to the target organ. So for us, it should be very low-hanging fruit to develop companion biomarkers that help us decide who's a responder, non-responder for therapy. And I'm going to divide this in 3 examples. Cells, genes, and function. Not only to diagnose and treat, but our dream to prevent progression of disease, because as we heard from the previous talk, this is a disease that progresses until we treat it the right way. So I'll tell you the first example of cells. And that happened when I was at Duke, working with my great friend Danny Saban. We did what is called flow cytometry on tears. In other words, we took tears and we isolated cells. We took a homogeneous population of patients. One of my passions, graft-versus-host disease. We know that that's a pure inflammatory disease of the ocular surface. And when we did tear cytometry, what we do here is we stain every cell for different markers. So what you're seeing here is different. This is the normal blood. These are the neighborhoods of population of cells that we're seeing. We're looking at CD4s, neutrophils, macrophages, etc. So each dot here is a cell on a single patient. So this is a cluster analysis, unbiased, I'm not selecting this, where you can see that if you see big tears from the normal patients, they just have a small population of neutrophils. When we look at patients with graft-versus-host disease, sure enough, not only do they have CD4 T cells, but they also have this population of neutrophils that is very distinct. In other words, can we extrapolate this to the clinic and start developing biomarkers to treat in a specific fashion patients that will have this phenotype and will respond? So we're not treating neutrophils yet, but I'll give you an example of how this can be done. So I'm very lucky working with another European company, Oculus, that developed OCS02, an anti-inflammatory therapy that allows for dry eye. So they developed an eye drug to block TNF-alpha. So OCS2 is the first in class humanized antibody fragment that inhibits inflammatory cytokine TNF-alpha. Humira, Remicade has been amazing in rheumatoid arthritis. Why we have not thought about this for the treatment of ocular surface inflammatory disease? It binds TNF-alpha with high affinity, it's soluble, and it's of course a low-hanging fruit to treat anti-inflammatory dry eye. So sure enough, Oculus did a small study that actually looked at patient vehicle versus OCS2, and what they found was really interesting. There were some responders, and what you see here that there's this group of population of patients that had a really good response to the drug and not the vehicle. But taking it to the next level, gene biomarkers or precision medicine, they also did what's called a pharmacogenetic study. In other words, they had the genes from these patients. And when they analyzed what do these patients have, basically what they had is they looked at polymorphism in 3 pathways of TNF-alpha variants, HLA variants, TNF-alpha receptor variants, And sure enough, well, surprisingly enough and not surprisingly enough, luckily enough, they found that there was a small population of patients that had this polymorphism in this NIP that actually was responsible for the patients that responded to the drug. And this has to be, it was a polymorphism in the TNF receptor 1 pathway. So it really makes sense with the mechanism of action and your drug to have a companion biomarker. So guess what's the next study? Now it's going to go in phase 3, it's a clinical study, where they're going to involve patients that have this polymorphism, and you're going to ask the question whether they respond or not. And that makes sense. It makes your clinical study smarter, specific, homogeneous. And listen, even if you get 25% of the response, then 25% patients are going to be very happy when you give this medication. You're going to be 25% of our 100% of the doctors are going to be very happy that they respond, and 25% of the market is not that either. So, what about typical neuromodulation and sensory deprivation? This is what Giovanni asked me to talk about. So I want to spin this down on the same theme of biomarkers and precision medicine, because definitely controlling the innervation of the cornea is going to be key. So as you heard yesterday from Benitez and everyone, confocal microscopy really gives us a good picture of what corneal nerve looks like. So, and we know, this is a great slide that Jesus Mirallo gave me, of a publication they had with him and her team of neuromodulation in the cornea, Dr. Carlos Belmonte. These are the receptors that we're talking about. So these are the target therapies we're going to be thinking in the future. Corneal nerve that responds to touch, pain, temperature, warmth, and cold. And these are the family of receptors that we're looking for. And today, I'm going to tell you how we're going to block these substances, because that's what we're looking for. And I'm going to give you two examples. Now we give it TRPV1, which was the original title of my talk. I'll give you two examples of pathways for molecules that have been used to block that. And the second pathway, TRPV8, is a cold receptor, and I'll give you another example of that. And it's very interesting. So for topical neuromodulation, I'll start with TRPV1. It's traction receptor potential amyloid 1 receptor. It's a traction receptor that allows you supply TRPV1, a receptor that maintains dual function for pain. Actually blocking it actually prevents pain in dental patients. And it was actually Dr. Benitez del Castillo at one of the first studies in Spain trying to silence this receptor for the treatment of dry eye. And there was a signal. It showing that that actually is the right pathway. And in the United States, in collaboration with Novartis, there was a small molecule that was taken from the oral medication and topical medication, SAFF3112, the that actually showed that it was safe to use as a topical medication. This was published in TBST. And then, of course, the next study was it working in patient with dry eye? Well, actually, it was not a dry eye experiment, but a clinical trial. The first one was used in PRK to show that it diminished pain and does not affect the ocular surface, and the results were positive. And thanks to this topical application was then taken to the clinical phase 2 trial, which we were part of in Boston Palmer and Duke University, where topical ocular TRPV antagonist was used for the treatment of chronic pain in patients that undergo surgery, etc. Unfortunately, those results have not been published, and since the last time, Novartis sold this asset to Bausch & Lomb, and we're still waiting to see the next effects of that. But I'm very positive, especially for some neuroimmunoproliferation. And then finally, interstitial receptor potential MA, or TRPMA. This is another family coming from Dr. Belmonte's brain. It's actually a receptor for cold receptor. Has shown that it actually leads to increasing inflammation stimulation of basal production. And sure enough, I don't know if you heard, but in the United States there were two studies. First study showed efficacy and safety, and now most recently two phase 3 clinical trials, COMET-1, COMET-2, COMET-3, where it shows efficacy and safety in the treatment of patients with dry eye, changing symptom, more specifically Schirmer's production. In other words, this was just launched in the United States, you'll be seeing it soon. It's called alcohol-announced TIP-AR1512, better known as acoltremon, and that's going to be the new path to complement the therapy of dry eye from the corneal nerve innervation point of view. So I want to leave you with a final thought about another biomarker. We're going to start using biomarkers for neuromodulation. We've been working with Real Engine and looking at corneal cystometry, a very important I call it functional biomarker for the treatment and evaluation of patient response to therapies, and what better not to use this for the non-ambulatory therapies. And I'll be talking about that on my next talk. And so I want to leave you the final vision and thought that, you know, precision medicine is here to stay. And it's us for us to make it better and better in the ocular surface. And that we should continue to exploit the use of our brains, our clinical gut feeling, and correlate that to cells, gene and function, again, to diagnose, treat, prevent dry eye, and allow us to do and design really good clinical trials that are good, are smart, will be cheaper, and actually help us identify responders, responder patients in our complex treatment of the ocular umbrella of dry eye. Thank you so much.
Thank you very much for the press. Very interesting. Now, Samana will tell us about the use of cyclosporin in EYEAlla.
Thank you very much. Slide screen?
No.
So the USB?
Non funziona. Just a moment, please.
See, it's very simple.
Just a moment.
If it's not working, I'll come to you, but you can proceed the next talk. This time.
Non work.
No. Okay. Can we go next talk and then I'll check what's going on? Alright.
L'importanza of breathing,
All right, while my slides are going up, 250 years ago, the U.S. broke away from the Brits. Why did they do it? They didn't want to pay taxes. George Washington didn't want to pay taxes. Well, it's 250 years later, and Melissa and I are paying a ton of taxes, so I have no idea about America. And I'm not going to sing. All right, we're going to talk about conjunctivalis. So it's something that we're seeing more and more of, but I'm going to start this talk a little bit differently instead of jumping right into it. I really think that before we do any type of surgery, we have to take care of dry eye. So some of the things that I'm seeing is patients that have surgery who have dry eye, and what do you see? You see bad complications. So these are actually dry eye patients that had surgery somewhere else and they wind up coming to our place. So a very simple surgery like a panguecula surgery, and you see this is the result. And it turns out that dry eye patients have a lot of inflammatory mediators that are being produced in their tear film. Interleukin 6, interleukin 17. When you actually do biopsies on patients with conjunctivalis, they have an increase in MMPs. This is another patient. Came in for a simple pterygium surgery. I presented this last year. Simple pterygium surgery in an inflamed tear, dry eye, and this is the result, complete blindness. This is post-op result, and like I said, I presented that last year. So if you take anything from this, if you're a surgeon, take care of dry eye first, and then do the surgery. All right, let's get to the conjunctivalis procedure. So some of the things I already mentioned. Now, it's very interesting is that if you read the books that we were taught, conjunctivalis is elastosis. But they did histology on these conjunctivas, and it's all over the board. There's some patients that show these elastosis, and there's some that don't at all. Now, why are we seeing more conjunctivalis now than we ever have before? I think it's medicamentosa. If you talk to patients who have dry eye, they're given an artificial tear by their doctor. right? The doctor just gives them the artificial tear and says, you have dry eyes, start using an artificial tear. That patient goes home and they think that that artificial tear, they can use it all the time. Now, what they do is they don't actually use the artificial tear that you give them. They go to the pharmacy, and in the pharmacy they see all these dry eyes, and guess what they do? They pick the cheapest one, right? They pick the one that's $2.99, but what does that have? It has BAK, it has all sorts of chemicals, and are they using it once a day or twice a day? No, because the doctor didn't tell them how to use it. They're using it every hour, every 30 minutes. And that's causing destruction of the ocular surface. So this is why we're seeing more and more conjunctivitis. So there's all sorts of ways of treating this, one being drops, but we want to actually get away from drops. And I've tried every surgery in the book. I've tried excision, amniotic membrane, everything. So I'm going to show you what has worked the best. I've been doing this now for about 10 years, and each year I refine this technique. So let's go to the technique. So it's heat, not burn. So if you read in books, it says thermal cautery for conjunctivitis. I find that you don't even need very much heat to actually shrink the conjunctiva. So the first thing that we're going to do is, and the video's kind of going slow, first thing we're going to do is a little injection of lidocaine underneath the tenons to blow up the tenons and the conjunctiva. Then we're going to use a very low cautery, and I call it touch, no touch. So this low temp cautery you can push to get heat, and then you can release so that you just get a little bit of heat. And it's just like saran wrap. You just put a little heat on that conjunctiva, and it shrinks down. And you don't have to use much heat to shrink this down. So the videos are going kind of slow, but it's touch, release. So push the button, let it heat, release the button, a little bit of heat, and you get it. Now the main thing and the most important thing in terms of this type of surgery is you want to use, I use capsulorhexis forceps, 90 degrees. What does that do? That lets me, in a big area, clamp down on the conj, but you want to get conjunctiva and tenons. So procedures that are just touching the conjunctiva aren't enough. If you do not bring in the tenons with the conjunctiva, 3 months later, the patient will have conjunctivitis again. So you want to grab tenons and conjunctiva. And then what you'll see right after the procedure is the patient, I don't put a patch, I don't do anything. I put a little bit of steroid antibiotic ointment. I give them a little bit of Lumify, as Melissa was talking about yesterday, and they don't have to wear a patch. So what do we do post-op? And again, these videos are going really slow. I'm not this slow. I'm a lot faster at this. So post-op, I use a steroid antibiotic. I know it's going to have a preservative. I'm going to try to get them off of the preservative. If you want to do preservative-free, say you have a dry eye patient that has a preservative allergy, you can use Lotamax ointment, which is preservative-free, and you can use moxifloxacin, which is also a preservative-free antibiotic. Use that 4 times a day. Now we have preservative-free Lumify. As we talked about yesterday, the Lumify actually brings in the conjunctiva and gets it away from the lid margin. That's something that we presented at ARVO a few years ago. Now, if you're worried, say you have a patient that has a lot of inflammation or you're worried about inflammation, then you can actually use platelet-rich plasma. And let's talk about PRP a little bit. The only time I've seen complications with this procedure is you have to tell patients, what we've done is we've constricted your conj. We don't want you looking at the site of where we did the procedure. The procedure has been done underneath the lid, so tell them, don't look there. Don't go like this and go, because patients will send me pictures and go, you don't want to do that. And this is what they look like. This is 1 day post-op. They look a little bit red. If you put a drop of Lumify, that redness will go away. And this is how they look. And the conj is completely sucked in and not bothering the lid margin. All right. So how many people use autologous serum? It's great, but it's very diluted. Some people use autologous serum and then they put in BSS above it. So you're talking about serum, which is 55% of the blood that you've drawn, and now you're putting in VSS 30%, 50%, 70%. Instead, we use platelet-rich plasma. We're the only specialty that's using autologous serum. There's not, orthopedics is not using autologous serum, neurosurgery is not using autologous serum, plastic surgery is not using autologous serum. They're all using platelet-rich plasma. Why? Because it has a higher concentration of anti-inflammatory mediators, has a higher concentration of nerve growth factor. So we've measured this. Compared to serum, there's 20 times more of these growth factors and anti-inflammatory mediators than there are in autologous serum. So we need to make ophthalmology and optometry needs to make the jump to platelet-rich plasma. So now there's machines and technologies that really break this down for us. So here above, this is lowest concentration, so we call this platelet poor plasma. And then here is where you have your highest concentration of anti-inflammatory mediators. This is called the Buffy coat. It's the area with red blood cells, progenitor cells, which are scaffolding, that somebody was mentioning before, some white blood cells, and some platelets. But here is the good stuff. So now the technologies that we use can separate that, and then I've discovered a way to make this into a drop. So another way that we're using this PRP, and this was Dr. Nude. She showed me this and showed me her data, and I'm excited to see her talk about her studies using PRP injected into the lacrimal gland. I'm actually doing something that is in the aesthetics world called microneedling. So these microneedles, actually you can secure the depth. This is a 0.5 millimeter microneedle, and I inject it right into the meibomian glands and into the lacrimal gland. So I take some of the PRP that I'm making for drops, and I actually use it to microneedle, and I'll give you more information as we complete the study on what it's doing for the meibomian glands and the lacrimal glands. Panguiculus. So there's a new study showing that dry eye symptoms improve when you excise panguiculus. So I'm excising more and more panguiculus. I don't know why the video isn't starting there, but patients feel better when you take out the panguiculus. And same thing as I do with pterygium, same thing as I do with chalasis. You want to get rid of tenons. Tenons is the problem, it's not the conjunctiva. The tenons is coming forward, so you want to do a wide berth excision of the tenons. Again, I'm sorry that the video is not going. I'm almost done. We talked, Dr. Benitez presented cortisol in the ocular surface. This is another thing. So say the patient has an inflammatory disease like rheumatoid arthritis, some systemic inflammatory disease that you worry is going to create ocular surface inflammation that's going to affect their surgery. You could use ACTH, cortrophin. So cortrophin is an injection that patients do twice a week. It actually hits, not only makes endogenous cortisol, but it hits the melanocortin receptors to bring down inflammation. So it decreases overall systemic T cell formation and all the inflammatory cytokines. We actually did a paper, we published a paper showing that cortrophin in the most severe of severe dry eye patients where you tried everything else can actually improve the signs and symptoms of dry eye. Thank you very much.
No, we're gonna go my.
Amada,
Yeah. Okay. Thank you.
the use of cyclosporine in dry eye management.
Sorry about the technical issues. of cyclosporine. I mean, brilliant talks earlier described the role of anti-inflammatories. And when it comes to that, you realize that actually we have very limited how many anti-inflammatories we have, like immunosuppression, steroid-sparing immunosuppression treatment. What? Cyclosporine, tacrolimus, Zypro. Anything else? Very things that's very rare in the pipeline, but nothing really in commercial use. So let's talk about what we have, cyclosporine. Right, okay. So you know the mode of action cyclosporine, I don't need to go that, but remember it's work on T cells. So it's shown that actually it has that multiple effects, and it's not for every case, and at least the license is not for every case. This is reserved for cases what are moderate to severe conditions, where you believe there may be MGD with inflammation, you have evidence of inflammation, and if there's obviously those autoimmune diseases, Sjogren's syndrome, for example, and don't forget those after LASIK, for example, after refractive surgery, there's more evidence that actually the clinical application is very useful. So, there's a lot of noise in the background. Sorry guys. Hello? In the back, please. There's a back noise. Great. Okay. This is what I'd like to draw your attention to, is indication in children. I don't know how many of you using cyclosporine children. Who use cyclosporine children? It is, excellent. So the license is Werner disease, but actually children, as yesterday, the beautiful talk, dry eyes in children. And the children, the inflammation in children is more aggressive. It's not like adult chronic low-grade dry eye inflammation, it's very aggressive. So that's why for the case here, for example, say 4 times a day, because once a day is very big concentration, it's not enough to suppress that peak of inflammation you see in allergic eye disease, Werner disease. But it is widely used now, cyclosporine, as probably a licensed treatment before you try something else not licensed. And this is the list of indication when we use cyclosporine for children. And obviously, you're familiar with that. It's worked on really good evidence here. And I was privileged to be involved in a real-life study for Santen with the non-eye care vest. And we've done a study on hundreds of patients to see the efficacy in their life. And we've done all PROMS outcomes, measuring the upper state, and all that. So all these parameters do get better, which is amazing. So that tells you something works here. But there are challenges with cyclosporine. I'm sure all of you use cyclosporine, you have this. Let's start with delayed onset. Patient expects quick response, but it is not. It takes at least 6-8 weeks with the eye care vest, for example. I always tell patient up to 3 months to get the efficacy. Look at other things, the burning sensation, and that's why compliance drop quickly. Patient come back, too much burning, I don't like it. Are you sure it's helping me? It's burning my eyes, how it's helping me? So that's a lot of chair time. Tell patient, convince them, please do it, please. Put in a fridge before you put in your eye, add lubricating before you put the drops, something to try to help to the compliance with the treatment. And obviously, we treat blindly. When you are practicing where you don't have the luxury to have the biomarkers and anything else on a basic, sometimes it's not really obvious there's inflammation or not, and doesn't work, there's no surprise, because it's not inflammatory, it's not going to work. Or doesn't work because the license for cyclosporine eye care vest in the UK, for example, is once at night. This is the guideline, so I want to prescribe the HS, I have to justify why I'm visiting the patient 2 to 4 times a day rather than once a day like the license. But I know it's weak, it's not enough. And when you have implant disease, it's not going to work. Access and cost, again, it's not cheap, not everyone can afford it, especially long-term, private sector, so all these have to be factors. And now, it's suddenly a luxury, we have 2-3 brands, right? So now which one to use, right? We should stick with the one, for example, me, I've done a study for eye care vest, I'm happy with it, but there is something that stings less. It works quicker. So let's see what other things here. So this is a kind of some brands we're familiar with. Restasis is the oldest and longest. Eye care vest, obviously the oldest in the UK and Europe. But now we have the Sequa and we have the tier 1, which is Vivi. And there are a few others as well. Okay, so eye care vest, very simple, is cationic emulsion. So the technology relies on this positively charged particles which interact with negatively charged epithelials to penetrate better and so on. So that's why, and it's lasted for once a day, but it stings, and patients don't like it. Sequa On the other hand, actually it does not stink, right? And the technology is slightly different. It relies on those particles you can see in the box on the bottom right. So you have this molecule which can trap the drug inside, and it penetrates the cells in better way. That's called cell technology. So apparently it's faster in acting, and so not faster, is more effective in penetrating the tissue. And that's what we believe is the advantage. But it does not sting or sting less. I'm going to compare those in a table in a minute to make it easier for you. And the latest one, which is not available here yet, being in the States, so colleagues from the States will be familiar with it more. So the VIVI, or the VVZ, whatever they call it, I don't know what they call this name. They try the most difficult ones and have to get Z or S in it. Right, so it's FDA approved. The good thing about it is quick actions, and the claim is going to take 2-4 weeks if you get a response and does not sting much. So what is changing questions? What's changing here? So we have, as I said, many of them now, at least those 4. Which one are you going to use? So if we compare, I'm going to highlight the stuff that probably matter the most, the concentration, because you can do the compound yourself, right? If you have a pharmacy, you can help you with it. But the concentration, probably you see that the VIVI and ICAP have similar concentration, sequel is less. But what matters also onset of action, and you can see here the VIVI is 2 to 4 weeks compared with ICAP is up to 12 weeks. And then the comfort, the most comfortable one probably between sequel and VIVI. So who's the winner here? I'm not biased, coach biased, I don't have any financial interest. I would go for VIVI. To me, it's work faster, quicker, comes in a bottle, so maybe better. We have to try, might come next time, let's see, talk to you and have different views. But the other challenge is what protocol to use, how many times? There's nothing set. It's everyone doing different things. I'm sure in this room we have 4 or 5 different ways to treat the patient. I like to start with anything that treat 1 to 4 drugs based on how severe is the disease. And I know that I'm not going to have full response, so I see after 3 months, you assess 3 months, and then you say, right, if it's working, great, could carry on, because I want to see you after 6 months, 9 months, but then we decide what happens next. Because I want stability for 6 months before we change the dose. Or it might not work, but it's still inflamed, and you know this pathway is not working, there's different inflammatory pathways, this is better approached by different products or different immunosuppression treatment. Or if there's no inflammation is not working, that means from the start was not really necessarily the right indication to start cyclosporine. The big challenge is how long do you start cyclosporine for? Are you going to be there for life? Patient ask this question, and need to answer them. I'm going to give it to you for your life. Gosh, patient don't like it. What am I have a cancer or something bad? But it is reality. Some of them need it ongoing. However, there's some unpublished data that after 1 year, there is the difference between the placebo and the product itself, at least in the ICAP base, would be comparable. So maybe you won't have to think, maybe after 1 year you need to reduce or give it. So I do the patient after them, okay, take it off, reduce it, and then we can see how it works. So I want to stop, this is what we got just about. The ideal candidate is only inflammation, right? It's not for someone with neuropathic pain unless there is inflammation, that's important. And some people believe that treating the inflammation, you help promoting regenerating corneal nerves, so that's the value of it. What if patient doesn't respond? Okay, well, this is just one of the things we discussed for it. Okay, poor tolerance, how do about it? Just put it in the fridge. They love it, right? It's cold drops, it sits nicely, and use artificial tears, or just use different products. Now we have, as in the luxury, we have additional 2 products. Okay, there are questions you don't know the answer, right? Do you really want to base your start the treatment based on some biomarkers? We can measure MP9 now, we can measure ADR, and you see in a minute in the table how each of those can influence your management, right? And testing for monitoring after 6 months. If you test HLA-DR, tell you whether actually they respond or not. So that's as a marker of response to treatment. It's great because so far we're treating kind of based only on clinical symptoms, but not on and few signs, but nothing really more than that. And when you switch to tacrolimus, for example, if I present to you someone with allergic eye disease, right, or with dry allergy, are you going to start cyclosporin or are you going to start tacrolimus? Personally, I believe tacrolimus is more powerful in terms of allergic eye disease, especially in children. So again, there's no right answers here. And the compound, I heard some of you doing it, you have your own pharmacy, do it for you, and you get better concentration. I was in Egypt a few months ago, and they said, we use 2% in the pharmacy. I said, beautiful work, but I don't know of those studies to prove that. And so this is where actually NMP9, when it's innovated, that's a really a good tool to tell you a strong indication to use cyclosporin. EYEAlla is really to tell you with a marker of how the response to treatment of the way. Obviously, you can look at the ACAM1, if you can impression cytology, look at complete cell density, and so on. There are a lot of things now, obviously, improving. Thanks to that, we can have more biomarkers available. Just want to finish by saying this is probably future how we manage those patients, right? So you look at the patient, you do you think it's a dry eye, inflammatory condition, you measure the NMP9, that's maybe okay, yes, I'll start with cyclosporin. Then you measure the ocular surface staining, you might do EYEAlla to see is response to treatment, is titers drop, and that's maybe that the response well, they know how to continue or not. But obviously, future is more, because thanks to talking about the TRPV1, talking about better cytokines that you can measure it now in the lab. So hopefully when you have those tools give you a lot of cytokine measurements in the tearful, I think that's going to be revolutionary, where you're going to look very different. So just a quick message here. It is for chronic ocular surface inflammation. Concentration doesn't have to be higher and frequency higher to get the same efficacy. Obviously, there are challenges, and hopefully with the new products, we're going to get this easier for us. And the future, I think, is great. Thank you very much.
Thank you, Doctor. We have to wait 20 seconds for computer problems. But we can introduce a new communication, Dr. Pedram Amra, with the role of tear stimulants in dry eye disease.
Good afternoon, everyone. I'm trying to give you an overview of tear stimulants, how it evolved. Thanks to the organizers for the invitation.
Facciamo di soluzione. No, ok.
These are my disclosures. Right, so I'm going to talk about oral security-drugs, nothing started, including pilocarpine and cybelamine. We'll talk about extranasal neurostimulation and also now more recently the topical security-drugs.
Go.
Perfect. So oral pilocarpine was the first neurostimulant that came out in 1999. It acts on muscarinic receptors, and basically what it does is results in increased saliva and tear production. The original studies in 1999 showed in 373 patients a significant improvement in both the global assessment in dry mouth and dry eye in this case, with the 5 milligram being the more superior in this one. It's not going.
It's the third one. That?
Right. And here you can see the results showing that the dry eye as well as the dry mouth are better in this case in this randomized multicenter trial. In 2003, about 4 years later, there was a follow-up study in a 12-week trial, also showing that the vision analog scale as well as the Schirmer's one test got better with the rose Bengal as well. And you can see that here again, compared to artificial tear use or punctal occlusion, the pilocarpine resulted in a significant increase in terms of the symptom scores in these patients, so it was superior to those in this case as well. There are, however, significant side effects, and it is basically a list of these side effects. As you can see, excessive sweating and headaches and flu-like symptoms are the most common ones, in addition to some oversalivation in these cases. And so cybelamine came out later, and cybelamine is a new generation anticholinergic, which binds also to M1 and M3 receptors in this case. In 2002, the original study showed that in a 12-week randomized trial, patient received a placebo or 50 milligram of cybelamine or 30 milligram, and that in terms of measurement of total saliva and dry eyes, these patients with 3 times a day of 30 milligram showed superiority in terms of the tear flow, as well as the symptoms of dry eyes and overall dryness in these Sjogren's patients, as you can see here. But also with cybelamine, their symptoms are much less. Most commonly, only 13% of the patients there's abdominal pain, and so it's much better tolerated compared to pilocarpine. Next slide, please. Great. And so comparing these two secular dogs, both pilocarpine head-to-head to cybelamine. Next slide, please. It's not wrong.
Sta cambiando.
Great. So, while he's fixing that, the 3 placebo-controlled trials head-to-head basically showed that pilocarpine was associated with improvement in dry eyes. The 2 placebo-controlled trials with cybelamine also showed about 39 to 72% improvement compared to the 24 improvement in the placebo, and the efficacy of security was better compared to the treatment of dry eyes and the dry mouth as well. And that in general, a patient with Sjogren's syndrome, they're more likely to continue the cybelamine rather than the pilocarpine in this case. Next slide, please. Great. So then we get to topical and neurostimulation in general on the surface or through the nose, and there are several things out there. The original was the True Tear, which is now discontinued, and there's Tyrvaya, and now there's also the ITR 100 in this case. This works to the stimulation of the nasociliary nerves in the nose, which is the sister nerve of the ophthalmic nerve in this case of the ciliary nerves in the eye, and basically through stimulation of the sister nerve, we get additional stimulation of the lacrimal gland, we have tear production, with electric, with the True Tear, chemical through the Tyrvaya or varenicline, or through mechanical stimulation now in the extranasal neurostimulator that we have. And so the first studies that was done with the intranasal neurostimulation, which was electric, was a 40 patient in a prospective open-label trial, and And that study showed both improvement in tear production as well as symptoms of dry eye disease, as you can see here. And that continued with a single stimulation through the day as well. And you can see that the effect of nasal stimulation on the tear production was kind of significant duration over long days, so there was no setback with continuous use of these as well. This also resulted in increased meibomian gland production as well as mucin production. And you can see that the goblet cell release was also stimulated with this. So basically it does not stimulate just the aqueous layer, but also the mucin and the meibom layer as well. In terms of varenicline, the original onset 1 and onset 2 studies compared different doses. It showed that in the onset 1 and onset 2 that patients with varenicline, that both doses had significant increased tear production. Here, as you showed here in blue and dark blue, and that is also improvement in the symptom scores as measured as early as the 30 days, which continued at 90 days as well. In terms of side effects with the neurostimulation to the nose, the most common ones are nasal pain and discomfort, transient intranasal discomfort, occasional nosebleed, and migraines as well. In terms of the extranasal neurostimulation, the ITR 100, that's the study in 101 patients showed in a multi-center trial of 180 days that these patients, after use of the device by 30 seconds twice a day, had significant improvement quite quickly in terms of both post-stimulation Schirmer scores, as you see here in green compared to the placebo, and that the OSDI score, which kind of showed the symptoms of these patients improved as well within 14 days and remained stable as well. So you had both improvement in signs and symptoms of neurostimulation. Finally, in terms of topical secretagogue, there's different lipid stimulator, mucin, and also topical secretagogues for the tear. The most recent one that was just FDA approved is the acyltrimine, which is also called Tripteer. It's the first-in-class tryptamate agonist, approved just a couple of months, less than a couple of months ago for signs and symptoms of dry eye. What it does, it makes the cold receptor, and through binding of that, creates a cooling sensation in the patient, and also stimulates the basal tear secretion. So the original study, the COMET-1, showed that the efficacy was quite significant at 148 days, which was recently published, but the COMET-2 in these trials, in these pivotal trials, that the majority of these patients had an increase in the Schirmer scores of more than 10. In a COMET-2, it was achieved in about 42% of patients, compared to only 8% in vehicle. And in a COMET-3, it was achieved in about 53% of patients, compared to the vehicle at 14%. In terms of safety, the most frequent noted issue has been mild transient eye pain that you can see in about 50% of patients, which goes away quite quickly. And then finally, there's some aqueous secretagogues and lipid secretagogues that are not available in the US yet. For example, cipotazole has been approved in Japan. It's a P2Y2 receptor agonist, which results in increased mucin secretion. And there's insulin-like growth factor available that can do that as well. And there's also Lacutin and Lacuprep, which are additional kind of drugs currently in clinical trials as well. Thanks for your attention. And here are just the kind of other mucin secretagogues that are available in terms of the trials with the verapamide, which is in Japan approved, but not in Europe or US. And also the JPP485, which also promotes galectin, which is kind of part of the mucin layer, which is also not approved at this point. Thanks for your attention.
Thank you, Dr. Hamra. And now, Sonia parte with the last about amniotic membranes, properties, innovative library system, and ocular systems.
Hi everyone. I would like to thank the organizers for inviting me. My name is Sonia Tedesco, and I'll be talking about membranes, amniotic membranes, the ocular surface, and how to deliver it to the eye. Just gonna wait to the
Samir?
Yep.
Right, so as we know, the definition from T+2 3 slightly changed to, from the one from T+2, but we still have the epithelial roles, which would be the symptomatology of our patients, instability, high osmolarity of the tear film, inflammation and damage. But what I want to know as well is what T+3 said about the amniotic membranes. So if slides go forward, I might be able to start. So, so the available literature from T+3, which is new from 2017 until now, said that both amniotic membrane and its drops are a valuable tool for helping the surface of the eye, but not only just for the inflammation, but for the oxidative stress. So, what is the amniotic membrane? The amniotic membrane is the innermost layer of the placental sac, and it helps and protects the fetus to develop. But it also has very similar, it provides protection, as we said, for the fetus, but it has really good benefits also for other tissues and certain areas of the eye. So at least in the UK, amniotic membranes and transplants are held by the Human Tissue Authority. I'm not too sure how it is in Italy. I know that it's slightly different. There's different laws and regulations to follow through. But you still need the traceability from the patient all the time, all the way through the patient that you're delivering it into. So one thing that is very interesting is how closely similar it relates the structure of the cornea to the structure of the amniotic membrane. We have the epithelial cells, we have the stroma, and then we have other layers at the bottom. So it's very similar. That's why it can be used as a patch or as a graft for scaffolding. In terms of the properties, apart from being a physical barrier like a bandage contact lens would, you still have that membrane which soaks the inflammation. It also has really good properties that helps the new cells, the epithelial cells, to grow and to proliferate onto the tissue area. Yes, so the amniotic membrane has certain properties. It's immunoprivileged, also it plays it into the eye. So that means that it can inhibit or modulate inflammation that we have in that surface, apart from not creating scars, not creating new blood supplies, and avoiding tissue adhesions. So that's really good when you have ocular issues. So there's different ways of keeping the membranes. You can have it cryopreserved, you can have it freeze dried, you can have it heat dried, but if you have anything that's freeze, it has to be freeze at -8, which means that you need a cold chain from the beginning all the way to the end. So nowadays there's more new treatments such as dehydrated preservation methods, because you don't need all of that cold chain. So still, any preservation method will alter the properties of that membrane from a fresh membrane to the eye. So we still need to be aware that all of them would have an impact. So when we would give an amniotic membrane? Well, anytime that you have epithelial disruption, such as recurrent erosions, persisting effects, but also when you have burns in the eyes, chemical burns, thermal burns, when you have certain conditions that could adhere in between tissue formations, and any other one that could create a scarring, or you could have that adhesion between the eye and the lid. There's also been some cases, some case reports used for when there's scanners, when there's been Salzmann nodular surgery as well, or even in HSK. So those are cases. There's also been some studies of using amniotic membranes for surgery, after surgery, just to avoid adhesions as well, in different mechanisms, either folding it, walking it around the muscle, and there's been some case studies as well on surgery cases for glaucoma when there's trabeculectomy. Other things, how are those tissues applied? So you can either have it as a graft, you can have it as a soft tissue, you can have it dehydrated, as we've mentioned, you can have it in a ring, you can have it placed on a soft contact lens and then into the eye. So we're going to talk about these types today. So if you have it as a graft, you can use it like fabric glue, you can suture it into the eye, it depends on which area you need to have it on. Now, I'll show you a couple of pictures here, there's a patient of mine, the eye was open, you can either pre-dry the surface of the eye, put the amniotic membrane in there, or if the surface is already altered, you put a membrane instead, and then you put a contact lens on top. That's to hold the lens. So it might be difficult to see, but it's right in here, it's round like so. And then this is how it looks with the contact lens on top. Now this is one way to do it. I know that in America they tend to do it this way, but for example for me, I prefer doing it slightly different, which is going to be the next slide. So I'm not sure if the videos will play. But what I do is I place it inside a contact lens and then I place it onto the eye. Let's do on the other slide we can see it better, so you can play that one for me. So this video might be a bit slow, but I'll just walk you through what I do in here. So what I do is I get a soft contact lens, not a normal soft contact lens, but a bandaged contact lens that has sort of like a bit of a reverse work. What I do is I pre-dry the interior of that lens, and then I place the amniotic membrane inside. That way, I wait about 10 minutes. That way, the amniotic membrane is locked onto the lens, and I know that it's a safe mechanism to deliver to the eye, so that membrane will not move. Well, the video's not playing, but I can show you later if you come around. Let's move to the next slide.
The way that you just described is to avoid that the amniotic membrane is not away.
Yes, yeah, to avoid slippage. Yeah. Yeah, exactly. So yeah, the video is playing way too slow, so I don't think we're gonna make it on time. But either way, we can move to the next slide. Thank you. There's different ways of applying. This video will not play, but that's all right. This is a conformer ring. Conformer ring is just placed under the upper eyelid, and then lower eyelid it sits in there because of that conformer ring. Likewise, you might still feel a bit that ring. Now, in my next patient, you'll see the picture right underneath. The anatomy of that lid is quite different, so they might feel it more. And that's why in certain patients, they put like that fake tarsorrhaphy on the upper lid to avoid that touching in there. So what I do is, as I said, is slightly different, but in terms of treatments, in terms of companies, in UK I use New Vision because Procura is not in UK anymore. There's other global markets, so these products can be found in the global market. Now most of them tend to move to dehydrated membranes rather than cryopreserved membranes. And for what I could find in Italy is the Fondazione Banca dei Tessuti di Veneto. I found that they have this treatment and also biohealing. So, but those are still, one of them still in clinical trials, and they're not yet sure about the ocular surface application. And the other one, they just said that in certain cases, it might be used for ocular surface. But before we go on to the conclusion, I want to raise this point, and I would like you to come to me during break, and I'm going to discuss this with you. Because in most of the literature that I've found, I've seen that they've mentioned that the membrane completely dissolves. Now that's not been my case. I put it under the lens. This is a week after. This is when I put it, a week after. I put it, a week after. The membrane is still there. In my case, a week after. And in certain cases, you can even see that it's even more whitish. We've done biopsies of these tissues, and we've seen that inflammation has gotten into the tissue, onto the amniotic membrane. So we do believe that the membranes are either not dissolving fully, or maybe what people are reporting is that the membrane has leaked. So if you've come across any of these cases, please grab me and let me know your thoughts, because I'd be very interested to know what you think about this. And then, well, as a conclusion would be, when are you using those tissues and why? Anytime you have an environment that is, you have a damaged tissue, or you want to inhibit that inflammation, and when would you use it? In any of those conditions that will lead to any of those causes. And how would you do it? I normally do it by direct application, either by a conformer ring, or inside the lens, or in suture. That depends on your case. Now, as you've seen in some of the images that I had before, the membranes that I applied, they have a hole in the middle, we've cut a hole in the middle to allow for vision, so you can still deliver the treatment while allowing normal functioning. So this is all for me. Thank you very much. And if you have any questions, let me know.
Why don't you put it on a pig eye and just leave it on there and just see how long it lasts?
Yeah, I just have to find a pig eye and I need the ethics for it. Yeah.
Find the big one, the eye. The big one.
Thank you very much.
Thank you again for the invitation, and I appreciate the time. I insinuated in my last talk that we should continue to find biomarkers to study and understand diseases of the ocular surface. And I finished that talk with one what I call a functional biomarker, which is corneal sensation. How many of you measure corneal sensation in your practice? Very important. We learn a lot from that. So I'm going to tell you through experience with the use of a non-contact esthesiometer in dry and beyond. And what I'd like to do is, again, like I did in the previous talk, continue to push the envelope and say that what we don't see or feel, we can't understand. And I would say that probably our limitation with all these new diseases, new but old, that we could not see them before or feel them, and now we can, especially neurotrophic keratopathy and dry eye. These are my disclosures, and I'm very lucky to work with Brilliant. Since I saw the technology many years ago, we're very transparent, said I want to try this in my practice and see exactly, does it work, doesn't work, and how can I use it. And for me that was very obvious, because I'm a very good friend of Dr. Carlos Belmonte. And Dr. Carlos Belmonte has been the pioneers in understanding corneal innervation, receptors, and how to test them. And the thing is that Carlos has this huge plot to test corneal sensation, so of course he could learn. But you know how many of those folks exist in the world? Probably 3. I don't have one. So this new technology of having that small box in a small instrument came for me was very obvious and very exciting to test. So this is a photo of the cornea. What we can't see, we cannot understand, or what we can't feel, we cannot understand. This is the classic diagram that we see of the corneal subepithelial plexus and the corneal innervation. And I'm also a scientist. So working with Alain Chadotal in France, we developed a mouse that all the corneal nerve express a green fluorescent protein. And when we put this mouse into a 2-photon confocal microscope, and we take a photo of the cornea, this is a confocal of a human. This is what the confocal of this mouse looks like. So every nerve is labeled there. You can see, like we talked in the previous talk, that this nerve innervation of the cornea is vast, complex, and very important. And we published this in IOS a couple of months ago. And so when we think of corneal sensitivity, of course, it's trying to find that biomarker of function in our corneal diseases. And there are many of them, right? We have corneal sensitivity changes not only in local diseases of the eye or surgeries that we've mentioned here, but also there's systemic diseases that actually affect corneal nerve, which make us kind of like the window of corneal nerve innervation for the rest of other neurodegenerative diseases like Alzheimer's, diabetes, etc., and multiple sclerosis. So we have the potential of being the gatekeepers or the fine of the gate to other corneal damage or neuropathy systemically. So we need to do a really good job in detecting them. So we also learn again from Dr. Carlos Belmonte that patients have problems with the corneal nerve, and all these receptors that we talked on the previous talk, which we're trying to modulate with therapy. And when we do confocal microscopy, I understand yesterday there were great talks on confocal microscopy. Our challenge is to continue first to find a new instrument, and second, how to make it objective quantification of that. But we know that there are changes in the optic nerve, and we have Dr. Hamra also in our audience who work vastly in this field. But we know that we see these changes in many diseases of the surface of the eye, dry eye, and neurotrophic keratopathy, which has made it that classic. So, you know, in ophthalmology and medicine, there are certain therapies that change how we see a disease. For us, in dry eye in 2007, cyclosporin, we had a great talk earlier today, changed how we think of dry eye. Now, for neurotrophic keratopathy, German that came here from Italy changed how we think of neurotrophic keratopathy. And although most of the studies were focused on patients with disease, stage 1, stage 2, stage 3, and 4, in the treatment of nerve growth factors, it really puts this disease on the map and asks and pushes to ask the questions, what about stages that are early? Because we learned that this is a progressive disease. The incidence prevalence is more than what we thought. We don't think it's an orphan indication anymore. And we need to continue to understand it, and that's where function and biomarkers is very important. And I'll show you our experience with that. So I'll continue to push the envelope, but we cannot feel, we cannot understand. And that's what we've been implementing, the use of non-contact extensiometer in our practice. So we do this in all our patients. And you heard about this yesterday from Dr. Benitez de Castillo as well. And you know, Professor Tedesco has been working with this instrument as well. And certainly, so this is a non-contact extensiometer that is friendly user for the doctor, friendly user for our technicians. We do this in all our patients. It's placed in the slit lamp, and we use it to measure corneal sensation. Cocheponet used to be known as the gold standard. We don't do it anymore. It's difficult. We cannot even find the filaments. And you'll see from our data that compared to non-contact extensiometer, the non-contact extensiometer is reproducible and easier to use. These are the positive about the non-contact extensiometer. Of course, it's non-contact. Patients are not afraid of it. Horrible. You have 5 levels stimulations from millibars, so you have quantification of your signal. So you can make it at levels or the millibar data. It's quantifiable, and I'll show you our data showing that it's operator independent and it's reproducible, and pretty much works kind of like a simulator of corneal sensation at the slit. So of course, we did our first studies and asked the question, is this reproducible and 10% vary between user to user? For us, that was important. We're going to use it all the time in my practice, in our practices. And we actually did publish a study in American Journal of Ophthalmology where we describe that when you have patients and we evaluate them between 2 observers, my fellows, and we ask the question if there's any variability between reader 1, reader 2, when we demonstrated that not, that actually it was very reproducible between the 2 readers and very reliable to be used and reproducible as well. Then we asked the question, what about in ocular surface diseases? And I have a very inflammatory corneal disease practice, and we also see a lot of dry eye and patients with neurotrophic keratopathy. And we asked the question, what happened to this potpourri of patients that we see in my clinic, where we're trying to assess what's the difference in corneal sensation between dry eye and perhaps neurotrophic keratopathy. And some of the preliminary data, one of the first things we did, we look at control patients or normal subjects, dry eye patients defined by questionnaire, ocular surface score, neurotrophic keratopathy based on score. And when we look at our data, we kind of develop, instead of having a single time point, we develop what we call the dose response. Kind of like when you do an audiogram, you do this in visible stimulation, and you see a curve of response. So we did the same thing in our patients. So our positive control, which would be neurotrophic keratopathy, is for stage 3. We actually stimulate the patients at different millibars, 2, 4, 5, 7, 8. And like we ask the percentage of patients receiving the stimuli, and you can see that in neurotrophic keratopathy, the curve of the dose response curve is very way down, meaning that of course these patients do not send the stimuli up to 5, 7, 8 millibars of sensation. And when we compare their control, here the cases, the graph in blue, you can see that our patients already at level 5 already have 4 or 5 millibars that already have a nice stimulation of sensation. So this is our comparison of this curve versus this one. And when we look at our patients with this potpourri of dry eye and inflammatory ocular surface diseases, you see that the curves are moving in different directions, and we're trying to quantitate that. Very interesting, we saw that in control patients, we have some patients that respond to 2 millibars, and the other member here in our audience, as the Victor, are these hypersensitive patients. And that's something that altogether trying to look into this to see if we have a way to look at that patient with ocular neuropathic pain. Working with Dr. Sabater, who just arrived here today to us, we actually look at the form of what we think neurotrophic keratopathy, our glaucoma patients that have been treated with medications and medicamentosa, which I consider a form of neurotrophic keratopathy. You can see that with physiometry, our patients that are taking glaucoma medications, the sensation is markedly decreased, and that correlates with corneal staining, clear rate of time, and meniscus height. So this is a perfect tool that I use to monitor our patients that are in glaucoma medication and push the envelope to my glaucoma specialist. You need to change the non-preservative or you can do surgery. And finally, we're using this also for other indications. I'm a corneal transplant surgeon, so for me it was very important to understand, can we use corneal sensation to monitor the health of my corneal transplant? And these are full-time keratopathies. This is a population of patients. And for what else was very interesting immediately, these are curved normal patients, responded at different bars. Certainly corneal transplant patients have sensation, is decreased, and what is present there. And now we're looking after corneal transplant, can I use this biomarker to continue the health of my corneal transplant? And my dream is, can I use it to see if there's any type of early rejection that I can see by decreased function of the corneal sensation? And this is a comparison of our corneal transplant population in using the non-contact anesthesiometer and also with Puchet-Bonnet. Both work, but it's easier to do, reproducible, and I can do in all my postoperative visits. So finally, going back to the first talk, I do think that what we cannot see, we cannot do, we cannot feel, we cannot understand is very important. And now that we have this new field of neurotrophic keratopathy, not new, old, but now better, and we're now starting to understand patients that have early disease, it's a disease that progresses. It's very important for us to monitor these patients, and instead of calling them, or maybe they live in that umbrella that we talk about dry eye, we have patients with decreased sensation, that's what we see in dry eye, and this is some data published, where we're using the non-contact anesthesiometer with sensitivity equals 3 versus 4, you may be able to start differentiating these patients. At the end of the day, understanding your disease and selecting how you're going to treat it is very important. And these biomarkers, functional biomarkers, as I call them, will be a very important part of our practice. Thank you.
Thank you, Dr. Tedesco. The next cataract surgery and management of post-surgical dry eye patients, Dr. Carlos Rocha.
Okay, so before I start, thank you, my friend Giovanni, for inviting me. I'm very happy to be here again. I hope to come back again to this amazing country and amazing region of Italy. I really like it. For organizing this amazing conference with such important people around the world, so it's a privilege for me to be here. So if you come. So before I start, how many of you do cataract surgery, more or less? Many of us, no? I think that people who don't do cataract surgery, I'm sure, they take care of cataract surgery. And when Giovanni told me, okay, to speak about post-surgical dry eye patient after cataract surgery, the management, I think I'm trying to convince you that as another part or another situation in their life, in my humble opinion, the most important is the prevention. So these are my disclosures. Sorry. According to these authors, and I truly believe in this, I think you are with me that the problem when you find before the surgery is the patient problem. No? Are you agree with this? You can say, okay, you have a problem, we need to take care of you. But the problem that we find after the surgery is our problem. The patient is always to say, I'm not happy because of you, not because of me. So we need to do something before. If we focus in the definition of the new choose freedom, you already know, and it's also in this Congress, it's already known that the most important in the dry eye disease are multifactorial disease. And we need to know that dry eye disease affects many people, and that's why we are here. We are here because we suffer dry eye, and we have patients who suffer dry eye. And according to some articles, in 25 years, it's going to be double. So we are going to see more and more and more and more patients suffering of dry eye. But what happened? For other part, cataract surgery is already known that it's the most common surgery, not just in ophthalmology, but in the whole medicine. And people normally who has cataract has elder or old people, and most situations have a problem because normally old people have more frequent dry eye, and of course they have cataract. So if we focus in the previous report of the Q2, this is interesting. In the iatrogenic report, the authors show, for example, James say that 62% of dry eye can be related to some drugs, systemic or topical. Other authors show that topical drugs, especially because of the preservative, has a role in the development of dry eye. Important, the contact lens user, you know that contact lens can produce dry eye, and this is important, the surgery. We do surgery in the eye, and we can have an impact on their development of dry eye. And after this appeared this concept of surgical induced iatrogenic dry eye, which was defined in the used report. So we have to know that cataract surgery can create dry eye. It is already known. For example, in this meta-analysis published this year, authors show, after analyzing all the literature, that dry eye can develop and may persist more than 3 months. So it is important. So why it's important? Because we need to know if their patients have already dry eye before the surgery. For example, other interesting study is was the FAGO study published almost 10 years ago. In a real-world study, which is also interested, not always is important the trial, of course, they are very important, they are in the top of the part, but the real-life studies, they are also important. And this author showed, you see this scale, that you see that more than 50% of the patients have 2 or 3 degrees of dry eye before the surgery. So if you see the table, they found that important percentage of the patients have low view, low Schirmer test, they have corneal staining and conjunctival staining. So we need to think about this. Not just because I tell, because evidence says there are many authors showing that there is a relation between cataract surgery and dry eye. Especially for those who do cataract surgery and the people who are focusing in these new premium lenses of simultaneous visual IOL, some of the complaints of the IOL is related for the dryness and not just for the optics of the IOL. It's very important, and we have to remind and at least think about it. Other interesting study published by the Italian group, which they are very strong doing research, and especially in ocular surgery. From my friend Antonio, they found that these unhappy 20/20 patients, instead of they have 20/20 patients, they are happy because they see in their population that have some kind of dryness after cataract surgery. So we need again to have this in our mind. So what goes, how cataract surgery can produce dry eye? Interesting review published in the current opinion some years ago. They say that cataract surgery can produce and important can worsen the previous dry eye. So it is an important cause of complaint after the surgery. And what is mandatory, we need to try to in a preoperative period to diagnose and if possible to treat before doing the surgery. Because of not, we are going to have this kind of patient after the surgery, and I think you are with me, it's very difficult to manage this patient. So, what causes dry eye cataract surgery? We know that the incision, you already know before, sure that you speak about this, the incision can damage this nerve and produce dry eye. Of course, the more the surgical time, the more the dry eye, because produce inflammation and because the thermal energy can damage the ocular surface. Also, inflammation that produce dry eye, and that's also important. The drugs that you use before the surgery, during the surgery, and after the surgery have that drug. Of course, some myometric dysfunction that the patient already have. And as previous said, some systematic recognition after. So, if we focus in intraoperative factor, what can we do? Of course, the less the surgical time, it is makes sense. We are going to produce less dry eye. And other important condition is the incision. It is also published that lower incision produce less dry eye than larger incision, which makes sense. But nowadays, most of us we do 2.2, 2.3 for millimeters. So here is more or less the resume. I think the most important, I hope you are with me, to do everything before the surgery. And not just because, as I said, because there are many evidence. For example, this nice video, they show that we need to treat the ocular surface before the surgery. So we need to identify the risk factor. There are low evidence, moderate evidence, and high evidence for risk factor that we have to know. And according to what test to do, of course, you are going to hear to learn about everything, the new technology, but I learned from one of my mentors, one of the master, Professor Benito Castillo, some years ago. He said that just with Schirmer test and fluorescein, we can diagnose dry eye. Because it's cheap, because it's available for everyone. Your boy showed this pattern of staining. We can differentiate between different types of dry eye. And another test that I learned, and this is very useful, and I did to my residents, is the Max line. And there is a correlation between dryness and myometric dysfunction and Max line. Is the cutaneous junction, and just with one drop of fluorescein or listening green, we can understand how is the meibomian gland dysfunction and how is damage. Of course, there are other algorithms, very difficult, but for the STAR group in American Academy, they say that we need to do this. It's very easy, it's very cheap, just to look, push, pull, and lift the eyelids, and with this we can understand. So, as I'm going to finish, the aim is in the preoperative treatment, identify and if possible, treat the patient. But of course, sometimes we need to also treat after the surgery, and there are many evidence showing that artificial tears or especially without preservatives are good option for this patient. As I told you, always without preservative and new drugs, as the previous speaker said, there are also publications using, especially in cataract surgery, also new technology like IPF, but there are other technology makes sense that also have a but there are no publications, at least 2 minors. So just to finalize, I want to recommend again another interesting and free article by an Italian group, which is very nice. I really recommend this. So, in conclusion, I think the most important is diagnose and treat before, of course, after surgery sometime, and if possible, use free yeah, it's easier to know. Thank you very much.
Right, I was asked to talk about neuropathic ocular pain, so I decided to talk about the management only because it's too much, the time is rather short. These are my disclosures for this presentation. So what's neuropathic pain? Neuropathic pain is caused by a lesion or disease of the somatosensory system. It can occur anywhere from the corneal surface all the way to the central nervous system. The symptoms are typically hyperalgesia or hypersensitivity, allodynia, photoallodynia, light, and they can occur with and without clinical signs of corneal fluorescein staining or abnormality of breakup time doesn't rule out that they have neuropathic pain. And typically these patients do not respond to conventional therapies. Mechanisms that result in neuropathic pain are twofold. Typically it's damaged neurons as well as inflammation, and we both have to be present. And in fact, we did serology in the last 10 years in our patients. About 70% of our patients have positive inflammatory autoimmune markers. So it's quite a different disease than dry disease. These actually not Sjogren's patients. In terms of how to diagnose and treat these patients, when we see these patients, we kind of do certain questionnaires, such as the ocular pain assessment survey. We rule out other diseases, such as conjunctivitis that Dr. Toyos talked about, allergies, anything else that may cause the nociceptive pain or inflammatory pain. We can basically have to do confocal microscopy to show structural abnormalities, which is required by the International Association for the Study of Pain, as we don't have any functional devices yet. And that will result in the definitive diagnosis of neuropathic pain. This can be differentiated into central and peripheral pain and can be easily differentiated through an application of an anesthetic drug. If the patient has improvement in pain completely, that's peripheral pain, as you see in green. If the patient has no improvement or worsening, it's central pain. And if the patient has partial improvement, you have mixed pain. What you see on the left is that out of patients that we see, typically 20-25% have complete resolution, and 25% have pure centralization, and that 50% are typically a mixed combination of peripheral and central sensitization. But what that also means is that 75% of patients with neuropathic pain have a central component at least, and that do require systemic pharmacotherapy, and that topical application of drugs alone will not be sufficient in these cases. What we do is also to try to trigger the pain and to see the confirmed hypersensitivity. What we have done in the past is to activate TRPV1 through using application of hyperosmolar saline. And more recently, the brilestaziometer allows to potentially diagnose these patients at the level 1 with potential hypersensitivity, but that has to get validated still. But this is what we do right now for activating the receptor. The patient has a 4 or 5 level increase within 20 seconds of this. That kind of suggests hypersensitivity of these patients. Now, depending on what the source of the pain is, if you have pure peripheral pain, you use neuroregenerative therapy and anti-inflammatory therapy, because the mechanism is both anti-inflammation and nerve damage. We also have to optimize the ocular surface. If there's a central component, they do require pharmacotherapy. And if they have systemic findings such as burning, numbness, etc., outside of the eye, we have to co-manage with the neurologist as well. Now, we use autologous serum tears for various reasons, and one of the reasons is that multiple studies, about 7 or 8 of studies, have shown that autologous serum tears has less inflammatory mediators than PRP or PRGF. Studies have shown that PRP has increased interleukin-1 and TNF alpha and IL-10, And so given the fact that 70% of these patients have systemic autoimmune or inflammatory disease, what I've seen in my practice is that patients on PRP actually tend to get potentially worse. And so I personally do not recommend using PRP for these cases. And with PRG, I would also be careful unless you systematically screen these patients and rule out any autoimmune or inflammatory disease. If you don't do that, it can get risky. So the original study we published back in 2015 was using patients with hypersensitivity to light. These are patients who responded to numbing drops. And we see that patients have pain levels of 7 to 10 out of 10, and that almost all the patients improved significantly within 3 to 6 months of autologous serum tears with anti-inflammatories as well. Here are the structural changes that you can see. Each image on the top row is the same different patient, and each image on the bottom row is a different patient. Same patient after 3 to 6 months, and you can see that the structural changes have improved within 3 months. The tortuosity improves, the microneuromas go away, and the number of nerves increase as well. This is shown in green compared to the red, that after 3 to 6 months you have a slight increase in the nerve density, but not back to normal level. You can take up to 2 years to get to normal levels as well. But you only need about 30% normal nerves to have normal nerve function in general, so you don't necessarily aim for complete normal nerve density in this case. The follow-up study we did was actually on pure pain. That was not light sensitivity, and again that showed that with 20% autologous serum tears in 3 to 6 months, we actually did get an improvement on patients who had 8 to 10 out of 10 patients pain. That get down to 6 or less within 3 to 6 months again, and again the nerve topography improved. So the autologous serum tears in conjunction with low dose anti-inflammatories work the best, because the problem is if you just regenerate the nerves and don't use anti-inflammatories, the new nerves can get sensitized again in a setting of inflammation. So the inflammation has to be controlled long term. There are patients who are quite severe, and serum tears does take time. In those cases, sometimes we use cryopreserved amniotic membrane. For short term, you can see that just 1 week application of cryopreserved amniotic membrane can result in about 70% or more improvement in pain. The difference is that this doesn't last, so you have to keep repeating it. So, but it's a good initiation therapy, or it's a good alternative if your patient has a flare-up on, like for example, serum tears and that peripheral pain. So confocal microscopy does show these structural changes, in particular microneuromas and low nerve density. The improvement has been shown to be the result of autologous serum tears or cryopreserved amniotic membrane as well. And so here's a short summary that you can see what we use. Typically autologous serum tears, 20 or 40%. I don't recommend higher doses because the patients can get worse. Corticosteroids as a pulse followed by a tapered therapy, and then cryopreserved amniotic membrane for initiation of flare-ups, and then important lubrication of bandaged contact lenses, scleral lenses for adjunct therapies as well. Now, if the patients don't respond, we also look at alternatives for faster relief. One of the ways which I just briefly showed you earlier was on neurostimulation for tear production, but we use it also for a different purpose, because by overstimulating the same nerve through the gate control theory, you actually shut down the pain pathway between 4 to 8 hours. And so what you can do, what we have shown is that a single application in the clinic, you can see in red, the pain levels after 3 minutes come down by about 60-65%, which lasts about 4 to 6 hours. And this is something patients can do at home. We actually did a follow-up study, which was a prospective open-label trial with the truth here at the time, and you can see that the baseline pain on the far right gradually comes down month by month. That many of these patients actually completely improved and didn't need the drug, didn't need the device anymore. Now, since that's not available, we now use an extranasal neurostimulator, and you can see that the pain levels go from 5 to about 2.5. And we can use an extranasal neurostimulator as an adjunct therapy for peripheral neuropathic pain. Now, the patients who have a systemic component, there's many different drugs that can be used. The one we have found to be the most effective are one-tryptophan, which brings the pain down by about 35 to 40% within 4 weeks. And you can see on the right that the majority of these patients respond in green and yellow. And you can also see that low-dose naltrexone is working quite effective, by about 30 to 35% improvement in the pain. It only works in about half these patients, but has a better side effect profile in this case as well. So So in summary, nortriptyline, low-dose naltrexone, or the combination of both if the patient has side effects can be used effectively treat the centralized pain. Others have shown gabapentin, periorbital Botox, granule therapy, and long-term trigeminal nerve stimulation as well in these cases. Here's a summary of additional drugs which can be done on paper that was published a few years ago, such as carbamazepine, carbazine, xylitol, and other things that can be used as well. And there's ongoing trials now in the United States for neuropathic pain since last year, where Pharma has now closed the first study in patients with partial peripheral pain. And the results are due to come out in a few weeks, actually. Finally, what we're going from here's just the data showing you that about 50% of patients have a positive anti-nuclear antibody, and that's why we don't recommend PRP or PRGF in these particular cases. This is different than neurotrophic disease or dry eye disease, where you can use that. And you can see that about a large number of these patients also have autoantibodies against nerve repair proteins, and those are additional reasons we have to be careful what we put on these eyes of these patients. And so going forward, we right now are trying to phenotype these patients and try to predict what they may be using to. We have done phenotypic cluster analysis on these patients in about 1,000 patients now. We have identified 6 different clusters, and we right now are trying to identify what each of these clusters will respond to. So hopefully in the future, we can actually, based on the phenotype of these patients, be able to tell you this is the best drug to use for this particular patient. And the phenotypic analysis is based on surface disease, based on symptoms, based on serology, etc. And what that basically shows is that there are different phenotypes available depending on age, post-refractive surgery, autoimmune, etc. Other groups also have worked in proteomics as well, such as the Valor's group in Miami, which is also quite promising. So thank you for your attention.
After coma is healed.
Buonasera e grazie agli organizzatori per l'invito. Io vi parlerò della scelta di una lacrima artificiale in pazienti che hanno avuto un trauma corneale come coadiuvante alla terapia microbica o antivirale in base al caso. Possiamo iniziare? Bene. Non inerente a questa sezione, sostituisco la dottoressa Goulart che non è ancora arrivata.
Un attimo, c'è un problema.
You have some question?
Yeah.
Doctor?
The microphone?
Thank you. Great talk on corneal neuropathic pain. So my question for those who really listen, and I love your phenotyping those patient peripheral mix and the central, and this is the way forward. The problem we face with patients for us is like, okay, go to pain management clinic, right? They come back after 3 months, nothing helps. I tried this and that. So until we get some outcomes from Mr. Duke, I'm really looking forward. What's your advice? I tell those patients, because it's a real problem, it comes back to clinic, they have this ongoing pain, and you right said that's probably 25-50% average. But how do you manage it?
I suffered through the pain management clinic before, so I decided not to use them anymore because they just treat it as any other type of neuropathy. And so diabetic neuropathy is treated differently than ocular neuropathy, and they respond differently because we've tried everything as well. And so they typically put them gabapentin or pregabalin, and they don't respond well to those actually, in fact. So we follow the data. I've tried all of them. I summarized the data, and for me, the nortriptyline and the adult naltrexone work the best with a combination of both before going to the third one, which could be like Cymbalta, for example, that we have. The big thing is if you take control of the pain management, we'll probably have a better outcome because you can change things faster rather than the patient has to wait 5 months or 6 months to go back and get the next drug, or you can adjust it. Because sometimes also the question is, why do you change the drug? So yes, the patient can have side effects, but by decreasing the dose rather than switching, you may get something out of it because the patient may respond to the drug, but the side effect may be prohibited by the level that you want it to. So by adjusting that, that will help as well. The second is, as you saw, 50% of the patients have a mixed peripheral and centralized pain. So just using the oral medication will not be sufficient. You have to use a separate peripheral component as well, and that's in the majority of the cases. So it's not going to be one or the other, but rather the combination of both of these.
Do you use topical anti-inflammatories like cyclosporine? Because you mentioned neuropathic pain is not common practice.
So what I do in the beginning is, at least for the first 6 to 8 weeks, use steroids. I typically use loteprednol because it doesn't penetrate as much into the eye, so the chance for having cataract and glaucoma is less. Once you have a pulse therapy, but let's say 4 times a day, then to twice, and then to once, after 6 weeks, then I go to about, I play with it between daily to twice a week until the patient is stable. Once the patient has been stable 2 to 3 months, then I start switching them to, for example, higher doses of cyclosporine, like 3 or 4 times a day. Because what you don't want is the patient to be getting better and then the new inflammation coming back, breaking through and causing the whole problem from scratch again. Sometimes they use a combination of cyclosporine as a steroid-sparing therapy to help the steroids go from less to once or twice a week. At what level I think it's rather safe to use.
Do you want to add something, Victor?
Thank you, Dr. Brown. Okay, the next one. Dr. dell'universo, please.
Yes. For parents and professors' parents, I would like if there a difference about corneal sensitivity between male and female patients.
Female more sensitive for sure.
Oh, no. No, that's an excellent question. We have not done that subgroup analysis. But you're coming to a really good important point because now that we're learning more about androgens as changes in the ocular surface, there's like one level response to that. So I would not be surprised that we see differences in changes. But that's a very important subgroup analysis we need to do. Thanks for that. And in comment to Dr. Hammer with neuropathic pain, yeah, I think the other important part is to detect those patients that have corneal sensitivity as ocular pain patients or not. And that might follow your question, but there's a good analysis to that. So for us, the non-contact and sensitiziometry is really a very important tool. And those low millibar patients, the 1 millibar, etc., again, Dr. Andra pointed out to me, are those patients that are hypersensitive. So we're starting to look into that in correlation to the form of hypersensitivity. And I want to point out too that, I was mentioning about the DUS-3, so the DUS-3 came out, and one of the recommendations of the DUS-3 is non-contact excisiometer should be part of the algorithm in analyzing patients with neuropathic pain, or pain per se, to start differentiating in which direction to go. Thank you.
Thank you. Question? Okay.
Yeah, good afternoon to everybody. I'm Dr. Montego, and it's also I have a question for Professor Alla. First of all, thank you for giving me the speaker. Secondly, I found the presentation very interesting. Every day I had the opportunity to work with my tutor and mentor, Professor Vigo, and with complex patients with often require treatment with rickettsia or like ARS or other drugs. So, my question is topical cyclosporin available in ointment formulation, and how do you use it?
Okay, so good question. Thank you for your comment on my talk. Cyclosporin in ointment formulation is available for vets, dogs, cats, right? And they use it frequently. It's very cheap, by the way. So some of the patients, we used to prescribe it as unlicensed, and patients go to vet shop and buy it, and also say not for human use, but it's still use it. Because the amount was 0.2%, so it's a high concentration. And they use it once at night, and I can tell you, it's very effective. Unfortunately, when cyclosporin from
allora scusa, facciamo Fedele.
into the market, you can't say go to the vet shop, you have to go to the pharmacy and get the newer product. So, but we noticed that the cost of efficacy. And when I gave this kit as once a day, I always said it's not enough. Even though I was involved in the study, and we told them that it's very weak, it's not really suppressing to the level I expected. And my work for very mild cases, even though like I said, moderate to severe, it's not going to work for severe cases. So the answer really, that answer is there is ointment version. In Europe, my knowledge is no longer one. In India there is human ointment version, but not in the region. If you're using cyclosporin topicals, my experience with acutase is maybe 3 to 4 times a day. Children definitely need 4 times a day because their inflammation is much aggressive than mine, rather than the adult.
Thank you, Dr. Ramada. We are ready for the
Allora, dicevo, casi clinici, cercherò di essere più rapido, casi clinici come queste, di sensibilizzazioni, saranno, questo è un trauma post-LASIK di un incidente stradale, un corpo estraneo, qui vedremo il prima e il dopo, saranno capitati un po' a tutti noi a livello clinico, quindi noi siamo andati a testare una lacrima artificiale con azione rievitalizzante da aggiungere a un agente ovviamente antimicrobico, antivirale in base al caso. E nella fattispecie abbiamo pensato di abbiamo usato una lacrima artificiale con 4 componenti. Queste componenti sono il fucoidano, il dilantenolo, il trearosio e l'acido ialuronico. Sarò rapido nella chimica dei componenti. Il fucoidano è il polisaccaride solfato che si trova sulla parete cellulare di alcune alghe e in alcuni tessuti di invertebrati marini. Nella fattispecie, nella lacrima è contenuto un fucoidano di tipo algale. La struttura è questa, cioè dei ripetuti residui di L-fucopiranosio legati alfa 1, 3 oppure fucopiranosi alternati con legami alfa 1, 3 ed 1, 4. Il fucoidano ha varie azioni biologiche legate al peso molecolare, alla composizione e alla struttura, che hanno come campo di applicazione un po' tutte quelle che possono essere le branche della medicina, ma noi ci focalizziamo ovviamente sulla nostra. Il fucoidano ha un'azione sui VEGF riducendone l'espressione, sia agendo sulla riduzione dell'espressione del recettore che sulla riduzione dell'attivazione del recettore. È un'azione antinfiammatoria sulle selectine di tipo P ed L. Da qui un'azione sulla degenerazione maculare senile, attenuando l'attivazione della microglia, e sullo stress ossidativo combatte i ROS e riduce l'espressione del recettore per l'attivazione dei ROS. La proprietà idratante dimostra riassunta in questa slide che porta uno studio di Fitton in cui praticamente a varie concentrazioni di fucoidano è stata misurata l'azione in base alla riduzione della perdita transepiteliare d'acqua verso il placebo. L'azione è di tipo antiossidante è lo studio Dorsman che è stato fatto su cellule di melanoma uveale su cui sono stati testati vari tipi di fucoidano a varie concentrazioni. Lo stress ossidativo è stato indotto da perossido di idrogeno. L'aumento della superossido dismutasi da parte del fucoidano quindi è un'azione di tipo protettivo su queste cellule dagli insulti ossidativi. Questi sono i risultati, quindi l'azione, per riassumere, antiossidante dimostrata da questi studi del fucoidano è essenzialmente legata al fatto che aumenta la superossido dismutasi, riduce il glutatione, attiva il fattore di trascrizione nucleare nitroide 2-simil-2 ed ha un'inibizione sulla generazione dei ROS. L'azione antinfiammatoria è legata alle selectine. Le selectine delle piastrine e dei leucociti sono delle molecole di adesione coinvolte nel processo infiammatorio. Il fucoidano impedisce il passaggio delle cellule infiammatorie negli spazi tessutari e da qui riduce la risposta infiammatoria. Blocca quindi la P-selectina, inibisce la cascata del complemento, riduce l'espressione del fattore di trascrizione nucleare K-beta, riduce l'espressione della proteina chinasi legata al mitogeno, riduce la produzione di citokine proinfiammatorie e inibisce la coxossigenasi di tipo 2. La proprietà anti-VEGF è legata appunto alla riduzione dell'espressione dell'H1F1 alfa, alla riduzione dell'espressione dei recettori del VEGF e alla riduzione dell'espressione delle neurolipine, che sono i corecettori VEGF neurolipina 1 e 2. Questo è uno studio a supporto. L'altro componente, la vitamina B5, il dipantenolo, che aumenta la proliferazione dei fibroblasti e di conseguenza accelera la riepitelizzazione, aiuta la rigenerazione dell'epitelio corneale, migliora l'idratazione grazie alle sue proprietà igroscopiche e crea un effetto barriera. Sul trealosio se ne è parlato tantissimo, quindi il trealosio stabilizza i lipidi, protegge le proteine della denaturazione ed è uno scavenger di radicali liberi, riducendo il danno ossidativo della cornea causato dai raggi ultravioletti e sopprime l'espressione delle citokine proinfiammatorie. Quindi ha un'azione sui danni ossidativi, protegge la cellula da danni ossidativi, da shock termico, dall'essiccazione, dalla disidratazione, dal freddo caldo e dall'ossidazione. Questo è uno studio a supporto che è stato già presentato, quindi andiamo all'azione antinfiammatoria, il trealosio riduce l'infiammazione associata al dry eye in vivo e in vitro con un meccanismo d'azione ancora poco noto. Questo è uno studio in cui il trealosio è stato somministrato a 9 pazienti con dry eye ed è stato confrontato con la carbossimetilcellulosa per 30 giorni, uno studio di tipo prospettico, randomizzato e monocentrico. questi sono i dati morfometrici e ultrastrutturali. No, mi è andata completamente, sta girando il loop. Vabbè, andiamo avanti. L'acido ialuronico è un glutamino semplificano anionico non solfato biocompatibile e biodegradabile che è in grado di migliorare l'idratazione e la lubrificazione oculare grazie alle proprietà igroscopiche e mucoadesive. Ha un profilo viscoelastico unico, in particolare ad alto peso molecolare e un'azione rievitalizzante, antinfiammatoria ed antiossidante. L'acido ialuronico ed il trealosio sono presenti in molte formulazioni che noi conosciamo, ma l'azione sinergica di tutte e quattro le componenti conferisce al collirio una proprietà appunto idratante, rievitalizzante, lubrificante, protettiva, antinfiammatoria e antiossidante. Andiamo questo invece è uno studio che mostra la capacità rievitalizzante di questo collirio versus il placebo, cioè non trattati, acido ialuronico 0,2 e 0,4. Vi faccio vedere solo le immagini degli studi che poi per cui volevo rapidamente. Questa è la disevitalizzazione, questo è l'effetto a 7 giorni. Questo è un trauma da flash di una persona che lavora in edilizia, questo è l'effetto sempre a 7 giorni. Questi sono i casi. Qui abbiamo un'infezione, colora, questo è un effetto dopo un mese di trattamento. Qui abbiamo un'altra forma di scompenso corneale legata ad una infezione in basso, e questo è dopo un mese di trattamento, ovviamente in questo caso c'è voluto l'antivirale. Questo è un trauma di una persona che lavora in edilizia, un pezzo di mattone che è stato tolto, e dopo, questo è appunto il giorno in cui è stato tolto, e questo è dopo 10 giorni di trattamento. Questo è il caso per cui ho pensato a questa relazione. Una persona che fa il pastore durante una mungitura ha avuto un trauma da corna di capra, che è una cosa molto rara, a me non era mai capitato in 20 anni. Ognuna di queste immagini, che poi ho preso con la Pentagram per vedere un attimino la profondità, è a 7 giorni. Quindi la prima, questa appunto a 7 giorni, c'è comunque un'emorragia sottocongiuntivale, sempre per il trauma, questa a 14 giorni, e questa qui è appunto, era l'ultima. Grazie.
Ci sono delle domande oppure facciamo un po' di break?
Giovanni, how are you? Good to see you. Thank you so much for everything. How are you? Amazing, amazing venue. Very excited.
That's right, that's what
Yeah, I had like 8 offers, but I decided to
Grazie.